Now we have also another clinical scenario, which is the valvular heart disease, ودكتورة سارة وحيد طنطاوي مدرس الأشعة بجامعة عين شمس هتقدم لنا role of cardiac MRI in valvular heart disease.
Thank you so much for the introduction. Always a pleasure to be with my colleagues and professors. Today I'll be talking to you about the role of CMR in valvular heart disease. Actually, the role of CMR is actually secondary in valvular heart disease. We usually start off with the echo, and echo is the main modality to diagnose the valvular lesions because it has high spatial resolution, high temporal resolution, so it's excellent in visualization of valvular anatomy and dysfunction. But also CMR has important additional information. Why? Because it can accurately quantify the severity of those lesions. That's the first thing. The second thing is we can know the impact of the valvular lesion on the ventricular system, the ventricular volumes and ventricular function. We can also visualize the surrounding anatomy like the aortic root and the aorta itself. We can assess the myocardial scarring and inflammation. Why is that? First and foremost, we have unrestricted imaging planes in cardiac MRI, which is an additional value over the echocardiography, which is limited somehow by the echo probe position and sometimes the poor acoustic windows of the patient. In CMR, you can do any planes along the cardiac structure as much as you can, as many planes as you can in order to address the valvular pathology in question. For example, here in this case, this is mainly focusing on the mitral valve. And the mitral valve, as you can see here, there is a regurgitant jet. And you need to cover all aspects of the mitral valve. So you do the general sequences that we take. These are cine images, SSFP. This is the name of the sequence. We do the regular 4-chamber view, which is here, the arrow. So this is the 4-chamber view here, and then this is the 2-chamber view, and then this is the 3-chamber view. And you can do each one of those in different slices or many slices as much as you need in order to cover all aspects of the mitral valve. And you can also do short axis images parallel to the mitral valve in order to see the coaptation of the mitral valve edges. And you can actually acknowledge that there is a defect here which is causing the leakage of the mitral regurgitation. Here you can see the mitral valve regurgitation jet very clearly. A jet is caused by defacing of the protons because of the high jet velocity across the non-coapted orifice. And you can also, because of the unrestricted planes that we can take, we can actually localize the exact leaking scallop of the mitral leaflet, and we can diagnose the severity and the number of scallops affected. So as you can see here, there is an anterior mitral valve leaflet and posterior leaflet, and each one of them is divided into 1, 2, 3 according to from lateral to the medial side. And you can take multiple planes across each and every level of those scallops. So for example here, this is a myxomatous mitral valve leaflet as mentioned before. We acknowledge the myxomatous mitral valve degeneration by thickening of the mitral valve and prolapsing of the mitral valve leaflets beyond the edges of the mitral annulus so that it prolapses into the atrial side. And as you can see here, there is multiple scallop affections. So the first image over here is crossing between A1 and P1. The second one is A2, P2. The third one is A3, P3. And all scallops here are actually prolapsing above the mitral annulus plane. So this is a multiple or multi-scallop affection. And you can also here, of course, determine the site of the leaking valvular affected and see actually what is called mitral annular disjunction, which is mentioned before by my colleague Ghada, which is the defect that is, or the distance that is present between the mitral annulus and the base of the LV muscle wall. So if there is a disjunction like this case over here, you can actually measure the exact distance of the mitral annular disjunction and acknowledge the LV systolic curling, which is the curling of the LV beyond the annulus. And this by itself is associated with arrhythmia, and if you find fibrosis which is easily detected by LGE sequence in the MRI, this actually puts the patient more at risk of ventricular arrhythmia. You can also take perpendicular planes along the edges of the mitral valve and do what is called the direct planimetry, and you can assess the area of the orifice that is leaking and leading to the mitral regurg, and this helps in assessing the severity of the mitral regurgitation. So if it is exceeding 0.4 centimeter, that is severe and probably will need repair. Also, you can use it in mitral stenosis. So this is a case of rheumatic heart disease in which you have like doming of the anterior mitral leaflet over here, and this is called a hockey stick appearance, and it causes also restricted mobility of the posterior leaflet, which will cause the mitral stenosis. And you can assess also the orifice area of the mitral valve, and you can acknowledge that there is bicommissural fusion, which is characteristic also of the rheumatic heart disease. And you can also focus not only on the mitral leaflet, you can take specific planes to visualize the aortic stenosis, which was also present in this case. We have the 3-chamber view, and we have the coronal LVOT view, which is dedicated to specifically acknowledge the aortic regurgitation or aortic stenosis that is present in the patient. And you can take axial images or parallel images to the aortic valve, which can show the restricted mobility of the aortic leaflets and malcoaption, which leads to the aortic regurgitation, and again, do the direct planimetry of the aortic valve. It can also help you to assess the morphology of the aortic valve leaflets. For example, this case is a bicuspid aortic valve. This is a unicuspid aortic valve orifice where you can see that there is bicommissural fusion over there and bilateral or two raphes, which leaves the aortic valve orifice to have just a single orifice. And then you can also detect other sites of the stenosis, not just the valvular stenosis. You can have subvalvular stenosis, like cases of Hocum, which was previously demonstrated by my colleague Mona. And you can also focus on other valves, similarly, like the tricuspid valve, if you take those planes along the RV. So this is a 2-chamber view along the RV, and this is a 3-chamber view along the right side of the heart. Similarly, we can do, like Marwa previously mentioned, the cases of tetralogy of Fallot are very commonly referred to CMR in order to detect or quantify the exact amount of the pulmonary regurgitation and see if there is also residual pulmonary stenosis. And you can do the planes along the pulmonary valve to see the shape of the pulmonary valve itself. For example, this is a case of bicuspid pulmonary valve, which causes stenosis in the patient. The second most important thing, or the second advantage of CMR in valvular lesions, is the flow and velocity quantification. And actually, this is a unique characteristic feature of CMR, because we have a dedicated flow sequence just to quantify the flow along the cardiac cycle. So this is like the Doppler of the ultrasound. We have, instead of red and blue, we have white and black. So the white is the to movement and the black is the fro movement. So anything that is black along the region of the aorta after the white has finished is regurgitant flow. Okay? And you can take it along any part of the cardiac structure as you wish. So you can take it along the aorta, along the pulmonary valve, any flowing structure, you can take it along it. You can do a perpendicular plane, which we call the through plane, and a parallel plane, which is called the in plane. So this is, for example, an in plane along the pulmonary artery. So you can see the to movement, which is the white, the fro movement is the black. So black is the regurgitation of the pulmonary flow. Okay. Not just that, you can do assessment of the stenosis. Like we mentioned before, if there is a liaising along the image that we took, it means that our VENC is not adjusted correctly. Our VENC is like the PRF in the ultrasound or in the Doppler. So like we use the PRF in the Doppler in the same manner. If the velocity is exceeding the PRF that you have chosen, you have to increase the PRF correctly. So the VENC also, we have to increase it in order to bypass the aliasing. And the more we increase the VENC, the more we acknowledge that there is stenosis in this region. So for example, in this patient, it reached 4 meters per second, which means that there is subaortic stenosis at this region. We can also, after the patient leaves the MRI, we can also, sorry, I will need a few seconds, a few minutes more. You can also directly quantify the regurgitant fraction by automated software. So you can do an ROI and automatically the software detects the regurgitant volume in exact absolute measures and also in a percentage manner. This is hard to do actually along the mitral and tricuspid valves because they are high, because of their high dynamicity. So instead we have other options to do, like we will mention later on. Also, MRI is very superior in ventricular volumes and function because we have dedicated sequences for that, and what you need to do is just to contour for the software, and the software automatically detects the stroke volume and diastolic volume and systolic volume, and you can use the stroke volume to measure the amount of mitral regurgitation indirectly. So you take the stroke volume minus the direct aortic flow that you measured, and you get the mitral regurgitant fraction, and this helps to identify the severity of the lesion. The other thing you can do, if available, this is just now, it's not very commonly available. This is a new technique called the 4D flow, which was mentioned also before. You take like 3D model of the flow and implement it along the cine images that we usually take. And you can directly, this modality allows you to directly follow the plane of the mitral valve, so you can do it along the mitral valve and tricuspid and contour it in the same way along any part of the cardiac structure and get the direct flow. Just a quick hint about the prosthetic heart valve. You can do CMR, 1.5 Tesla CMR on any type of the valve, except the ball and cage, which was used in very, very old eras in the valvular repair. You can otherwise do cardiac MRI patients safely as long as it's 1.5 Tesla. But you cannot, of course, see the direct mobility of the occluders in the metallic valves, but you can still quantify in the normal manner that we do. In the stent valves by prosthesis, we can still assess the mobility of the valve itself or the leaflet itself in the same manner we do for a native valve. In cases of this is a freestyle called the freestyle aortic replacement, which is also by biological replacement of the aortic valve. And here you can acknowledge that there is a very small mass, which is a small thrombus over the aortic orifice. And in cases of TAVI, you cannot still acknowledge the mobility of the leaflets because of the metallic artifact, but again, you can still use it safely and quantify your regurgitation or stenosis. And then just to sum up, the CMR is indicated when echoes are suboptimal, or there is discordance between the clinical assessment and echo findings, or discordance between different echo parameters that was done to the patient. And CMR has a great role in scar quantification, LV volumes and function, and to assess the severity of the valvular lesions. Thank you very much.
Thank you, Dr. Sara.